The next case that we're going to speak about is a patient with the chief complaint of fever and irritability. If we look at our history, we have a 19-month-old girl who's brought to the office because of a sudden onset of fever of 104.5 degrees Fahrenheit, and the patient has right ear pain. She's generally been in good health, but has recently attended a daycare center. So you have a patient who has right ear pain and also who's been in daycare and who has fever. That should make you highly suspicious that this particular patient has an acute otitis media. 2 days ago, she started to develop a low-grade temperature, and she also started to have a clear rhinorrhea. The mother says that she appeared to be irritable. She seems slightly better since the mother has been giving her some over-the-counter decongestant medicines. However, this morning, the child continued pulling at her right ear and was more irritable than previously. She appears easily consoled by her mother. This is an important point because throughout this case, we're seeing that the person who's giving you this history keeps using the word irritable, irritable, irritable. Whenever you have a patient who's 2 years or less who presents with just simply the chief complaint of irritability, you need to be thinking, does this patient have meningitis? Therefore, it's important somewhere in your case scenario that the examiner would say to you that this patient is consolable. A person who had meningitis would not be easily consoled. The other thing that you want to look at is the physical examination. It shows that the anterior fontanelle is closed. This does not give us an opportunity to, again, assess for meningitis to see if the fontanelle is bulging. The left tympanic membrane appears to be normal, and you have a right tympanic membrane that is erythematous and bulging. The nares have a minimal watery discharge with colorless crusting. Throat appears to be hyperemic without lesions or exudate, and the neck is supple without adenopathy. Now, even though they're telling us that the throat is red, we've learned from our studies that small children who are this age, 2 years, would most likely not have a strep throat. If anything, this would be a viral disease. So it's not the throat where you need to make your attention. You need to be concentrating on the fever, the ear pain. The lungs are clear, and the heart sounds appear to be normal with a mild systolic ejection murmur, heard best at the left sternal border. The abdomen is soft, not tender. There are no masses, and the extremities are without cyanosis, clubbing, or edema. If we think about this, for our differential diagnosis, acute otitis media, either bacterial or viral, is what comes to mind. Fever and this ear pain, this irritability, and the fact that they gave you the physical findings of a bulging tympanic membrane. However, for all practical purposes, you need to assume that this is a bacterial infection. And I would say that for purposes of your exam, that you would treat all with antibiotics, because it would be very difficult on examination to differentiate a viral from a bacterial otitis media, because it's very difficult for us as clinicians to do that in the clinic. So our final diagnosis for this particular case is otitis media. Now, if we think about what particular symptoms would help us to diagnose otitis media. First of all, pain. Second would be the fever. Third would be the fact that the mother might say that the patient is not taking food or liquids as well as previously. They might say that the baby is irritable. And in this particular case, the baby is not irritable because of meningitis, but the baby is irritable because the patient has pain. Now, another associated symptom is diarrhea. However, my question to you, or the thought I'd like to bring to you, is that the patient can have an otitis media and a meningitis at the same time. So the fact that they include that the irritability resolves if the patient is consoled by the mother is an important point. If the irritability was not consolable, you would have to assume that in addition to the otitis media, that this child might be susceptible to having a bacteremia and or a meningitis. Now, what are our findings here? We said that we had an inflamed, bulging tympanic membrane. If we looked in the ear canal, we would see that we had loss of landmarks and the light reflex. The key, if you could only choose one part of your physical examination, it would be that you have to have decreased mobility. What do I mean by decreased mobility? I mean that you're going to use an encephalator attached to your otoscope and see if the tympanic membrane moves. And why is that so important? If you took 100 children and examined their ears, they all may start to cry. 99 out of those 100 ears are going to be red. So if you just depended on color, it would be not that helpful. Everybody would have otitis media and you would be giving everybody antibiotics. Therefore, there has to be another way in order to differentiate who has a true otitis media. And the way we do that is by putting some air into the canal using our insufflator, and seeing if the tympanic membrane moves. If there's fluid behind the tympanic membrane, you will not have mobility or you will have decreased mobility. And so once they tell you that there is none to decreased mobility, you know you have your diagnosis of otitis media. What other things do you need to be thinking of as far as a general practitioner or a pediatrician? You need to be thinking that this patient is going to need antibiotics. The patient also has a lot of pain, so the patient is going to need analgesics. As far as the antibiotics that the patient would need antibiotics that would cover the most common organisms. And what you need to remember is that the most common organism from birth to death is Strep pneumoniae. All right? And that's for everybody. The next two organisms that you need to remember in these young children are Haemophilus influenza, but this is Haemophilus influenza non-typable. Therefore, even if the child had had a vaccine for Haemophilus influenza B, the patient is still susceptible to getting an H. influenza non-typable ear infection. All right? So just because their vaccines are up to date doesn't mean that they don't have that organism. The other organism that you would worry about would be Moraxella catarrhalis. So the organisms are Strep pneumo, Moraxella catarrhalis, and Haemophilus influenza non-typable. The medications that you would want to use would be those that would cover these organisms. The good rule of thumb is that in 70 out of 100 cases, amoxicillin will cover these organisms. Therefore, you would start with amoxicillin because it's tried and true, it's efficient, effective, and least expensive. If for some reason the patient was not able to take amoxicillin because of an allergy to penicillin, your alternative therapy should be erythromycin plus a sulfamethoxazole, a sulfa, in accordance to have synergy. And why? Because in this young age group, we said Haemophilus influenza non-typable could be an organism. And the erythromycin alone will not cover all of the H. flu non-typable. There'll be some resistance. Therefore, by adding the sulfamethoxazole, what will happen is that you'll have a synergistic effect to help you fight against that particular organism. If the patient has recurrent otitis media, you need to decide, is it the same infection? If it is, you can go to second-line therapy plus amoxicillin plus clavulanic acid, or you could go to the erythromycin plus sulfamethoxazole, or you could go to trimethoprim sulfas, or to a cephalosporin. However, if it's not the same infection and the patient ends up having another otitis media 3 months from now, you would start again with your tried and true choice of amoxicillin. What are some complications? Why is it important for us to be able to diagnose otitis media? Well, first of all, you can get mastoiditis. Another problem you can have is meningitis. You can have an effusion, which can cause hearing loss. If you have hearing loss and you're a child, you're always learning. And you're always improving your speech, your vocabulary, and so you'll have slowed speech development, decreased school performance, and so it's important to make sure that we would treat our children. I'd just like to give you one extra pearl, and that would be that if the patient on your examination or in your office has an otitis media, but they mention that the patient also has conjunctivitis, or they might say the patient has pink eye or an eye discharge, then your diagnosis for that particular patient is that the patient has otitis media conjunctivitis syndrome, and in that particular case, it's always caused by a non-typable Haemophilus influenza that is not, I repeat, is not susceptible to therapy with amoxicillin. Therefore, if you're reading fast and you miss your conjunctivitis, you're not going to know, forget amoxicillin, I've got to use an alternative therapy. All right? So what would that alternative therapy be? It would be amoxicillin plus clavulanic acid. Okay? So you would be completely wrong if you had a patient who had conjunctivitis and otitis media and you used amoxicillin. Although in most every other case, 100%, we use that as our primary treatment. All right? So that would be your clinical pearl. Okay, we're going to go to our next case. Our next case is going to be a patient who comes in with the chief complaint of irritability, malaise, and abdominal pain. If we look at the history, we have a 4-year-old boy who is referred to the office by his nursery school teachers, who are a bit concerned because he has increasing irritability, poor attention span, and lethargy. He also has been complaining of some vague, recurrent belly aches. He has otherwise been healthy. He lives in a pre-war crowded building in Chinatown and has a history of pica. According to his mother, he has a poor appetite and has been constipated. There's no dyspnea or fever that's been reported. I want to just point out that the key words here are that the patient has pica. That means that the patient is eating things that we shouldn't be eating. Dirt, cornstarch, detergents, things off the ground. Okay, so that's important. Paint chips. So he has a history of pica. The other thing that you want to put that together with is that the patient is lethargic, that the patient may be having some poor attention span, which would lead to developmental delay, that the patient is starting to get a little bit irritable, and that he has constipation, that's key, belly pain, and a poor appetite. All of that is leading you to the idea that this patient may have a lead problem. Add on top of that he lives in pre-war housing where we could have lead paint, or where lead paint was permitted. It might lead you to be considering as top choice that this patient has a lead intoxication. You start to examine the patient, and what you find out is he's non-cooperative, he's pale, he's afebrile. He has a pulse blood pressure of 90/60. He has a pulse of 120 and a respiratory rate of 18. On physical exam, it shows that his HENT exam is benign and his neck is supple. Cardiovascular shows that he has a 2/6 systolic ejection murmur, which is non-radiating. His lungs are clear. His abdomen has no masses or hepatosplenomegaly, but he does have some tenderness to deep palpation. His extremities show no joint tenderness. Neurologically, he's grossly intact. We've talked about what would lead us to a diagnosis of lead poisoning. That should really be the top differential, or top on your differential list. However, there are other things. that might be considered in the differential diagnosis. One of them might be iron deficiency anemia. Would go with poor appetite, all right? The patient may end up having hepatitis. The patient might be hypoglycemic, or could even have a thyroid disorder if he's sluggish. So we're going to have to think. We're going to have to work this patient up. Now, if you needed to work the patient up, one of the most helpful tests would be your CBC. Because you know if the patient had a lead intoxication, that this patient would have a microcytic hypochromic anemia. And so you're drawing the CBC looking for anemia. The other thing is that you need to make sure that you have a blood lead level, because you have that on your differential diagnosis, and it's probably your top choice given the surrounding factors. And so you want to make sure that you'd be able to make the diagnosis. We talked about hypoglycemia being in our differential diagnosis, and so we're ordering a glucose. We're going to look at electrolytes and the liver function test, because liver, something as critical as Reye's syndrome could give you lethargy, or liver problems could give you kind of an encephalopathy problem. As far as your CBC, you want to make sure that you look at your peripheral smear and a serum ferritin. As far as the results, you get a WBC count, and the hemoglobin is 7.3. The patient is anemic. You find out that the patient's lead level is 50. Normal would be less than 10. One time they had on the examination, how much lead do you need in your diet? The answer would be none. But they put trace, 5 micrograms, 10 micrograms, 25 micrograms. Remember that we don't need any lead in our diet. We get enough lead exposure in our environment. Other things, as far as our results, were pretty much within normal limits, except when you looked at the peripheral smear, one of the things that you found was that the patient had basophilic stippling. All right? Basophilic stippling points to the fact that this patient most likely has a lead intoxication. Now, if we think about our assessment, remember that your job as a physician and your job on the examination would be to interpret the laboratory results. So a laboratory result with a level of 50 is probably enough to make the diagnosis that this person is lead poisoned, especially since the patient is supposed to be less than 10 or have less than 10 level of lead in his body. In this particular case, this would probably warrant the use of chelator. One of the chelators that we use is the calcium-sodium EDTA. You need to be sure that you want to assess the home, because you want to find out where is the lead exposure. All right? Where do we get lead from? We can get lead from the soil, because in the lead-free gasoline days, the consumption of lead gasoline would land on our soil. And if you look at our inner cities, some of our children live in apartments or homes that are right along the highway. Other places that we can get lead from are when our parents work in smelters. They may bring the dust home on their clothes. One of the typical ones is the lead paint, especially if it was pre-World War II housing. We have some beautiful historic homes that when you start to refurbish, you realize that you're getting intoxicated with lead dust, because you have coats and coats of paint beneath the current one. All right? If you have lead pipes in your community, oftentimes you can get poison just from the water. Back in 1983, there was a medical student at Loyola who died from lead intoxication. She had gone to Mexico. She had bought a beautiful glazed lead pottery pitcher. She had put orange juice in it because she used to stay up late at night and drink orange juice instead of coffee. She didn't realize that the juice was leaching the lead right out of the pitcher. No one realized this until her autopsy. She died. And it was because she was intoxicated with lead. The other thing is if you're married or if you have nice homes, you might have a lead crystal decanter. This sometimes is on the exam. If you have wine in there for a long period of time, the wine leaches the lead from the crystal. And so if you're drinking that wine, you're actually poisoning yourself. So these are all sources of lead that we can get. All right, so what would be the treatment plan for this particular case or this particular child? Well, first of all, we'd want to make sure that we did some intravenous hydration because we want to maintain diuresis during chelation. We also want to make sure that if a patient truly had a level greater than 50, that prior to giving the calcium-sodium EDTA, that we also gave a dimercaprol, a lavage, which is called, in parentheses, BAL, British anti-Lewisite. And this would help to have a more efficient and rapid chelation. And then lastly, you would give the calcium-sodium EDTA. Now, we said that our final diagnosis for this particular patient was lead poisoning, and we've talked about the risk factors, the exposure. The presentation would depend on the age and the amount of exposure. So if I have a chronic lead poisoning, I'm going to have more and more symptomatology, the irritability, the developmental delay, the constipation. Other things that we need to be thinking about is that if you were thinking about an acute symptomatology, that these patients would have apathy or nausea, and they may end up having coma, seizures. That's how the medical student from Loyola had presented. Remember that children who are at risk are screened by finger stick blood lead levels. And that any child who has a lead level greater than 10 has an abnormal level. Now, the question is, are we going to chelate every person who has a lead level higher than 10? And the answer is no. Remember that you're going to screen every 3 to 4 months if the lead level is between 15 and 19. And you're going to do counseling, and you're going to give education and nutrition counseling. The other thing that you need to remember is if my lead level is greater than 20, that I am going to confirm this by a venous blood. I'm not going to accept that the finger stick is accurate. I'm going to confirm by venous blood. And what I'm going to do is refer this patient either to myself if I'm the medical person, or if a nurse is doing this, they would refer the patient for medical follow-up. Again, you want to do education, identify the source, and remove the child from the source of the lead. However, once I get to greater than 45 micrograms per deciliter of lead in my blood, this is very serious. And again, you need to confirm with venous blood, but if it's still greater than 45, you need urgent medical and environmental control or intervention. If you have a lead level between 55 and 69, then you want, again, to treat with the chelator, EDTA, environmental intervention, and in some cases, they would use Succimer. If I have greater than 70, I'm probably heading towards coma, seizures. I need immediate chelation, and this would warrant an emergency hospitalization. So on your exam, when they ask, what will you do next? Will you admit? Will you send the patient home? Will you put him in intensive care? By knowing what the interventions are, you'll be able to make the decision of where they can go for safety. All right? The other things that you need to remember is that if you did an x-ray on somebody who had a lead intoxication, and if they had been eating paint chips, those paint chips would be radio-opaque on an abdominal exam. Golotherapy, remove the child from the source of lead. We've discussed the therapy in detail. Remember that encephalopathy can occur after 3 to 6 weeks of actively ingesting lead. So if you have a child that's kind of chipping away their bedroom wall and just kind of eating the paint chips, if they do that continuously for 6 weeks, they may end up with encephalopathy. The next thing that we would consider in the differential diagnosis was iron deficiency anemia. Why? Because we have a microcytic hypochromic anemia. However, looking at the peripheral smear, seeing the basophilic stippling, that would not lead us to the diagnosis of iron deficiency anemia. The other things that you would want to think about are, what are my risk factors for iron deficiency? Low birth weight, inadequate diet, blood loss. The typical patient who has the diagnosis of iron deficiency anemia usually has a diet consisting mainly of milk. Therefore, a typical case on your examination would be you have an 18-month-old who drinks 64 ounces of milk. All right? First of all, 64 ounces is double the amount that anyone needs for a day. So that's too much milk. If I'm running around all day drinking from a bottle or a cup, milk, or fluid, I'm not going to actually take the other components of a healthy diet, the vegetables, the greens, the protein, all right, the carbohydrates. So you need to know that 32 ounces is the maximum amount of milk permissible to give a child per day. If you get this story, they may also tell you, oh, by the way, they're of Italian descent. Okay, why? Because in your test, they're going to put down that this patient has a microcytic hypochromic anemia. All right? And because you have the Italian descent or the Mediterranean descent, you might think, oh, they're trying to get at thalassemia, because we know that that's something in the differential that causes microcytic hypochromic anemia. Don't go there. Don't go down that path, because the most typical cause of the microcytic hypochromic anemia in a small child who's drinking all this milk is iron deficiency. So in this particular case, it would have a diet discussion with the parent, cut back on the milk, introduce other foods. You would draw a reticulocyte count at that particular visit. You would start the patient on oral iron therapy. Okay, you don't have to do any other workup on this patient. Oral iron therapy. Once you start the patient on this therapy, what you need to be thinking about is, I've got to bring the patient, this is a test question, I've got to bring the patient back in 5 to 7 days, because the best time to see if they're responding to the reticulocyte count is going to be at the 5-day mark. Test question. All right? If I am not responding, then that means I have something else. All right? So what could I have? I could have a lead intoxication, so you'd probably have to get a lead level. What else could I have? I could have a thalassemia, so you would have to get an electrophoresis. All right? What else did we talk about earlier? We talked about a Meckel's. If I had a painless rectal bleed, test the stool. See if you have a guaiac that's positive, because I may have a Meckel's that's not responding to iron therapy. All right, so you need to consider that in your differential. Remember that for the iron deficiency, spoon nails might be present, and they might have some tachycardia or be pale on physical exam because they're deficient. We said that hepatitis A might be confused with a patient who has lead intoxication, what you want to do is think about, is there a history of jaundice in family contacts? Friends, schoolmates, playmates. Have they traveled to any place that might be endemic for hepatitis A? The way we would transmit, typically, especially in this age group, would be fecal-oral. Clinically, they would have fever, nausea, emesis, abdominal pain. However, in small children, as opposed to adults, these kids get diarrhea. So if you see on your exam or on the question that the patient has constipation, even though adults can get constipation with hepatitis A, you have to rule it out with the child. So that would help you to eliminate that in your differential diagnosis. Remember that they might tell you that the stool the urine is dark colored. The patient may have jaundice, may have some right upper quadrant pain. And how you would make the diagnosis is with immunoglobulin M anti-hepatitis A virus, so the HAV, which would be detectable if the patient had an acute infection. The other thing to remember is to get liver enzymes is not really helpful to differentiate your etiology. If you ever suspect that you have liver damage, you need to make sure that you get a prothrombin time in order to assess. The other thing that you want to make sure is that if you do have a prolonged prothrombin time, they'll ask you, where will you send this patient? You're going to send this patient or keep this patient in the hospital. Your treatment for hepatitis A is going to be supportive, and chronic disease usually does not occur. One of the key things that we're finding over and over on the exam is they ask, when can this child go back to daycare? When can this child go back to school? Because if you approach this test as, I have to at least know what the generalists know, this is an important question if you were a generalist seeing families. And so remember that children with hepatitis A should be excluded from child care settings for 1 week after the onset of the illness. And usually by this time, their jaundice will be reversing. Other things that we talked about, hypoglycemia. We said that hypoglycemia may mimic or be on your differential diagnosis with lead intoxication. And remember, the definition would be to have a glucose level less than 40. What's the problem being hypoglycemic? You can have seizures, and you could develop mental retardation. There are many congenital problems that can cause you to have hypoglycemia. And if you found a patient that was lethargic and they present to your emergency center or to your office, you need to think the first step there, especially if they're in the emergency center, is to do a blood glucose at the bedside, a D-stick. And if the D-stick is low, i.e. less than 40, then what you'd want to do is to administer D10W, 2 mLs per kilo, followed by a glucose infusion. Remember that for these children who are older, oral diazoxide or somatostatin analogs are used as the treatment therapy. Other treatment choices or things that we need to be thinking about would be that the pancreatectomy would not be very optimal therapy for this young child, because by doing that you would make the child have a permanent diabetes and cause pancreatic insufficiency. In our long list of things that could cause lead intoxication, we also thought about hypothyroidism or things that should be considered in the differential diagnosis in our patient, and when you're presented with a patient who's lethargic or has manifestations of failure to thrive or constipation. And another thing to put in your differential diagnosis, especially for constipation, would be hypothyroidism. All right? Remember that sometimes these patients will fail to thrive. They might have decreased energy. Usually, the significant thing for our patient who has hypothyroidism that's acquired is that these children, schoolwork, don't suffer. If you think about a patient who's diagnosed at birth with hypothyroidism on the screening exam, then you would be thinking that, gosh, those people are developmentally delayed. The longer I go without replacing the hormone, the more chance I have of developing cretinism. When I say cretinism, I'm referring to those folks or those group of people who are only trainable to sweep the floor. Therefore, this is a good question to put on the exam. If the patient acquires hypothyroidism, the schoolwork usually isn't affected. Other things that you make sure that you do would be to do your thyroid screening test. And if you did have hypothyroidism, your treatment of choice would be to give sodium thyroxine. This will bring us to our next case, which is a patient who has chief complaint, rash and joint pain of the hands. You have a 17-year-old girl who has a 2-day history of facial erythema and rash. This appeared over her trunk starting today. She's also noted to have some swelling of her hands, which is painful when she tries to clutch objects. These symptoms were preceded by a low-grade fever not exceeding 101.6 Fahrenheit. She has a runny nose, pink eyes for the last 2 days, and she's usually in very good health. If you look at her immunization record, you see that it's up to date, except she's missing the measles, mumps, and rubella vaccine, which she received at 14 months of age. Remember, earlier we said that you must receive a second dose of measles, mumps, and rubella, and that this should be completed by the age of 11 or 12, if you did not receive it by the age of 4 to 6. The vital signs show that she has low-grade fever. Her pulse is a little elevated, which we might contribute to the fever, and her blood pressure is within normal limits. If we look at her HENT exam, what we find is that she has discrete erythematous macular papules that are involving the entire face, extending behind the ears. There are some confluent erythematous areas. She also has a mild conjunctivitis that's bilateral, and she has some pharyngeal erythema that's notable. In addition, we see retroauricular, post-occipital, and posterior cervical lymphadenopathy. The patient denies having any photophobia. To look at her skin and examine it, we see that there is a rash over the entire trunk, similar to the face, but there's larger areas of confluence. There's minimal itching, and there's no desquamation. Her neck is supple and gives no evidence that she has meningitis. Her heart and her lungs are normal, as well as her abdomen. If we look at her extremities, we see that she has full range of motion, but she does seem to have some slight swelling of the small joints of the hands bilaterally. Neurologically, it's a non-focal exam and the cranial nerves are intact. If we think about a differential diagnosis, we need to be thinking that this patient who has this rash, who has this adenopathy, probably has rubella. They're giving you a hint she's missing her measles, mumps, and rubella. Other things in the differential that sometimes are confused with rubella are roseola infantum, measles, scarlet fever, and infectious mononucleosis. If you wanted to do a diagnostic test, the first thing that you would do is order a CBC. In this particular case, the CBC comes back with 6,000 whites, 60% lymphs, none are atypical lymphs. The hemoglobin is within normal limits, as is the platelets. By showing you that the patient has 60% lymphs, they're showing you that the patient has something that's viral. Now you need to be thinking, are any of these lymphocytes atypical? If I had atypical lymphocytes, that would go with mononucleosis. They're telling you no. So that should be very low on your list for the differential diagnosis. This girl has rubella. Rubella is known as German measles. And it's causing the typical pattern of lymphadenopathy along with a mild coryza. So remember that red measles or rubeola causes high fever and a severe pharyngoconjunctivitis. But in this, the symptoms are very mild. In fact, sometimes it's referred to as the 3-day measles or the German measles. Also remember that sometimes these young women, usually it's women, but anybody, can have small joint involvement. They might have a component of arthritis. The patient is at risk for rubella because she never received her second MMR vaccine, which would be required by 11 to 12 years of age. So although we're not seeing these diseases frequently, they can occur. Now, what other diagnostic plan should you have? What should you be doing? Well, rubella is a reportable disease. Therefore, some of these rashes are confusing. Scarlet fever, rubella, roseola, many times look quite similar. Therefore, you would have to draw a rubella-specific immunoglobulin titer, and it would be IgM, in order to show that this patient was having active disease. The other things that you might want to get is the EBV antibody titers. Even though the patient doesn't have any atypical lymphs, maybe it's too early. So you want to make sure that you don't have mononucleosis. And also an IgG titer, because you want to see, did this patient ever have measles before? All right? And so her IgM is elevated, which shows that she has some active disease. Her IgG shows that she's not immune to rubella. And her EBV antibodies were within normal limits. What's the plan? This is a mild disease. It's self-limiting. So supportive care is sufficient. Some physicians may use amantadine, but it's not been successful in infants with congenital rubella. So our final diagnosis is rubella. Highlights of the 3-day measles or German measles or rubella are that the incubation period is 2 to 3 weeks, that there's a high incidence in teenagers because they're not getting their second dose, their booster dose of the MMR, and that they have this retroauricular and posterior occipital adenopathy. Other things are the upper respiratory symptoms that are associated with it. And the main thing that you want to be thinking about is that these patients may get what we call Forsheimer spots. And the Forsheimer spots are just red palatal lesions. On your exam, they may just give you that buzzword, Forsheimer spots, with a person who has a viral appearing symptomatology. As soon as you see Forsheimer spots, you know that they're talking about rubella. Other things that you need to know is that the rash starts on the face and spreads to the body, and that the females may get polyarthritis. Diagnosis is clinical. You should confirm it by serology because you don't want an epidemic of this. The treatment is supportive, and in order to prevent it, it would be immunization. Now, what about roseola infantum? What if you had, obviously, roseola is not going to be occurring in a teenager. Why? Because you know that the diagnosis can only be made in children who are really in the toddler stage, okay? So if I had an older teenager, you wouldn't say that they had roseola, okay? The peak incidence is going to be 6 months to 15 months of age. These kids also, though, are going to have occipital lymphadenopathy, and that's why it's in your differential diagnosis. They're going to have high fever, high fever, high fever, high fever for 3 to 4 days. And then what's going to happen? Suddenly, the fever is going to defervesce, and the patient's going to break out in a red rash. The mother may not have even come to you for the fever. She might have used the Tylenol. But now that the patient has this rash on the trunk, on the arms, on the face, she's there in your office. It's caused by human herpes virus 6, and once the patient has the rash, there's really no further diagnostic studies to do. It's just supportive care and reassurance. What about the red measles? The red measles are more serious. We said that that could be called rubeola. Remember that it has a prodrome, and the prodrome is the 3 C's. What does that mean? That the patient would have coryza, conjunctivitis, and cough. The patient may have a history of having Koplik spots. Koplik spots are small granule spots that are beside the 3rd molar that are on the buccal mucosa. Now remember that for German measles, they have Forsheimer spots. For the red measles, they have Koplik spots. The other thing that you need to be thinking about is that these people usually have significant fever, and that the rash starts at the head and works its way down, and that the rash will resolve in that distribution also, from the head to the feet. Diagnosis, again, is clinical, but there may be a presence of multinucleated giant cells in the nasal mucosa, which could help to make a diagnosis. Complications that you're worried about, the most common board question is otitis media. Yes, these people can get encephalitis. Yes, they can get pneumonia, but they're not as common as just otitis media associated with measles. The treatment would be supportive if you were in a third world country, or if you had a malabsorption problem of vitamin A. Vitamin A has been recommended for some of these children who have measles. There's a high mortality from measles, and therefore we want to make sure that these children we give good supportive care to. Remember to exclude these children from daycare until 4 days after the onset of rash. And as I said, the USMLE is starting to ask, when can this patient go back to school? And so you should know that this patient can go back to school 4 days after the onset of rash. How are we going to prevent it? Again, to encourage immunizations. What about scarlet fever? We talked a little earlier about scarlet fever. We said it was a group A strep infection of the throat with a rash. And whenever we have these red rashes that they describe, we want to make sure that we know what we're looking for. That would help us in a minute to make the decision what the next step is as far as treatment and management. Remember that these patients can present with fever, chills, headache, and even abdominal pain. The rash, though, may be described as macular-papular or sandpaper. The thing that you want to be thinking about is, we said that there was strawberry tongue, Postia's lines, circumoral pallor, and miliaria pseudomina is just small white dots that are sometimes seen, especially on the hands. How would you diagnose it? Rapid strep or throat culture. If the rapid strep was positive, meaning it was positive for strep, patient truly has strep throat. And with that rash, with the circumoral pallor, the Postia's lines, you have your diagnosis of scarlet fever. You could treat with penicillin VK. If the patient was allergic, you would use erythromycin as an alternative. However, if the patient had a rapid strep that was negative, but clinically you had strawberry tongue, circummoral pallor, Postier's line, sandpaper rash, you need to assume that probably they didn't swab appropriately, because a lot of times the child will close their mouth really fast. You're not even sure if you hit the tonsils. Or you know that there's at least a 15% of false negatives for the rapid strep. So you would probably go on clinical and treat that patient. The only other thing you could do is wait for the throat culture, which would be the next step, send a throat culture for confirmation. What else do we need to be thinking about? Children should not return to child care of school at least 24 hours after the appropriate therapy is initiated. And I think that if you say that the child shouldn't return to school until the fever has defervesced, that you'll be doing a good community service. What about infectious mononucleosis? What's important for you to know about that? First of all, the agent is Epstein-Barr virus. It's spread by intimate contact, usually saliva. It has a prodrome of malaise, headache, nausea, fatigue. The patient will have a severe pharyngitis with lots of exudate, and they may have palatal petechiae. Remember that palatal petechiae is not pathognomonic for Epstein-Barr virus because you can see palatal petechiae also with strep throat. However, if you have a generalized lymphadenopathy, if in addition they give you that the patient has splenomegaly, hepatomegaly, you need to be thinking about infectious mononucleosis. Now, for your test, the key question that they often ask is, you have a patient who comes in and they have a sore throat. And not you, but maybe your colleague, is busy. And they do the rapid strep, maybe you got them to do that much, and it's negative. And they say to themselves, oh, this person has strep throat, so I'm going to give ampicillin, or a component of amoxicillin. All right? Now, even though it was negative, because some of the people still treat throats without any cultures or without any rapid strep. So the test question is going to be this. The patient comes back, and the patient still has a bad sore throat. The patient also still has fever. But in addition, the patient has this red rash. Remember, because we're in the differential diagnosis of the red rash that look like measles. And they want you to decide what was the problem or what's the next step. They're hoping that you don't fall into their trap and find out, say that this is an amoxicillin allergy, because that would be your knee-jerk. But what you need to do is go deeper. And deeper is that this patient with all these physical signs really has Epstein-Barr virus. And you know that 80% of these patients who are treated with ampicillin or amoxicillin turn out to get what we call the ampicillin rash. It's an urticarial, they can also get an urticarial rash, but you'll know this, and so they'll ask you, what do you think happened, or why did this occur? And it's because you gave ampicillin to somebody who really had Epstein-Barr virus. So the next step would be, if they're older than 5, to do a monospot, or if they're younger than 5, to do Epstein-Barr virus titers. And the reason that you do Epstein-Barr virus titers and not the monospot in a less than 5 year of age is because you get a lot of false negatives in that age group. So you want to go to the specific titers. Remember that your diagnosis can be made on clinical presentation plus atypical lymphs in the peripheral blood. Treatment would be supportive. They'll ask you, what should you do about the splenomegaly? And you would advise your patient not to have any contact sports until the splenomegaly resolves. Remember that any patient who has recent history of Epstein-Barr virus should not donate blood. And that would lead us to our break.